Good evening, everyone. We have the PHIMC, Public Health Institute of Metropolitan Chicago, here doing a presentation for us on World AIDS Day. With us, we have Brian Gooding, him, a prevention coordinator at PHIMC. Brian Gooding supports HIV prevention services through Illinois Department of Public Health's Regional Implementation Group by delivering training and technical assistance and assisting with partner management, fiscal and program monitoring, and data analysis and reporting for RIG partner agencies. An advocate, activist, and sometimes agitator, Brian brings 20 years of experience advocating for people living with or at risk for HIV/AIDS. Rashonda Johnson, her, as manager of PHIMC, Rashonda Johnson provides strategic vision, guidance, support, and oversight for PHIMC's corrections and reentry program and behavioral health initiatives, ensuring synergy between these two portfolios. Prior to joining PHIMC, Rashonda served as a program specialist at Cook County Department of Corrections. She provided oversight and recruitment for volunteers for enrichment programs at Cook County Jail and facilitated psychoeducational and curriculum-based groups with both male and female detainees. Aleksandar Kajmakoski, I'm sorry, they, he, she, as program coordinator, HIV prevention at PHIMC, Aleksandar supports the planning and implementation of routine HIV screenings as a standard of care in healthcare delivery systems across Illinois. More specifically, they lead the Protecting Our Patients POP initiative, a cultural competency training program that addresses stigma in care settings for systematically marginalized populations. An activist, Aleksandar's work centers queerness, community building, and health equity. Roslyn Taylor, her, as routine HIV screening program manager at PHIMC, Roslyn supports and leads the routine HIV screening and cultural competency initiatives that aim to reduce HIV stigma in healthcare settings for marginalized populations, expands linkage to care, and improve health outcomes and quality of life for individuals living with HIV. Prior to joining PHIMC, Roslyn was a postdoctoral fellow at Northwestern University's Feinberg School of Medicine, where she researched mother-to-child HIV transmission and preclinical HIV vaccine development. Thank you.
Thank you, Janine, for those wonderful introductions.
Can you all see the slides?
Yes.
Great, thank you. So thanks everyone for joining us today. We're going to talk about the past and present state of HIV AIDS in the US and sort of its impact on or not to the COVID pandemic. So a brief little agenda for this session. We'll give a brief overview of PHIMC. We'll go through the history of HIV and AIDS. We'll talk about the intersection of race, politics, and HIV/AIDS. We'll talk about stigma as it relates to HIV and AIDS, and then we'll talk about the modern advancements and innovations and sort of any parallels between HIV, AIDS, and COVID. And then we'll open it up to questions. Though I'm sure, because it's a pretty small group, if people want to ask questions during the presentation, I think we'd be more than happy to answer them. So PHIMC has more than 20 years experience partnering with government and community health organizations. We are affiliated with the National Network of Public Health Institutes, and as such, we tackle critical health challenges in partnership with public health departments and other government agencies, community-based organizations and advocacy groups, academic and grant-making institutions, and healthcare providers and associations. PHIMC strengthens public health infrastructure through 4 major buckets of work, which are organizational development, system transformation, fiscal management, and program implementation. As such, PHIMC is made up of a team of entrepreneurial leaders that all play a critical role in developing and leading various programs, a few of which we'll discuss later on in the presentation as they relate to HIV. So I will kick us off just as a brief little intro. World AIDS Day what is it? It's held on December 1st of every year. And it is to show support for people living with HIV, to commemorate those who have lost their lives due to AIDS-related illnesses, and to increase awareness about HIV. And at this point, I'm going to pass it off to Brian to tell us a little bit about the history of HIV.
Great, thank you, Alex, and thank you, Janine, again. I'd like to start off by giving some disclosure here. What was missing in my introduction is the fact that I am a person of lived experience. HIV has been living with me on my terms. I make the rules for about 25 years now. And you know, I think about, sometimes I don't mention in my bio that because that's now, I've been living with HIV so long, it's the last thing I think about myself. When I think about myself, I don't think about HIV. I think about all those things that you said in the introduction, Janine. I think about being a friend, a son, an activist. All those other things came to mind before my HIV does. So I'm here, I'm going to give you a little history of HIV. And when they asked me to do the history of HIV, I thought, oh, geez, well, that's a lot. You know, there's like 6-hour documentaries on HIV, right? So I thought, well, let's just pull some key points and how I can relate that to my story as somebody that's currently living with HIV. I have skin in the game in this work. It's important to me. And when I think of what World AIDS Day means to me, it really is about, for me, it's really about looking back where we've come from, right? And taking those lessons to where we are now, where are we now with this epidemic, and all those things that we'll be talking about through this presentation. And then really that looking forward, that hope, right? What's the hope for the future? What does HIV look to the future as in the future as we try to get to the end of this epidemic? And so we'll talk about some of those things. First, you know, the first cases of HIV showed up in the United States in 1981. There were 5 previously healthy young men that were presented with a rare lung infection, PCP pneumonia, pneumococcal cystic pneumonia. It's usually people that are immunocompromised, old folks, young healthy folks usually aren't vulnerable to PCP. By the end of the year, there were 270 reported cases of severe immune deficiency among gay men. 121 of them had died by the end of the year. In 1982, really a group of cases of gay men in Southern California suggested it was sexually transmitted. And then this is where I believe the kind of otherization of HIV began, right? And that stigma began here when it was initially called gay-related immune deficiency, or GRID, right? They really labeled it and attached it to a community, which creates stigma. And then, of course, then it was the Haitians, then it was people who inject drugs, then it was people who engage in sex work. It was always the other. It was never never us, right? 1983, the virus is finally isolated by researchers at the Pasteur Institute in France, and we came up with the human immunodeficiency virus. We're really talking about humans. We're not talking about gay people. We're not talking about populations. We're talking about the human population. Next slide, please. So 1985, and I think this is important too, although AIDS was identified in 1981, the President of the United States did not mention it publicly for several more years during a press conference in 1985. And here to me it's about that it doesn't matter until it happens to me, right? And this was really, I think, spurred by the death of Rock Hudson in 1985, who was a dear friend of Nancy Reagan. So now we can talk about it. Now it's happened to somebody else in our community. Now it's not the others. So I think that's an important thing to highlight there. In 1990, we had the passing of the Ryan White CARE Act, or the Ryan White Comprehensive AIDS Resource and Emergency Act. This is really because of our broken healthcare system and the ideas of pre-existing conditions, right? So those folks that were diagnosed with HIV were not eligible for insurance. And so there was we needed a way to make sure those people were provided the care that they need. 1995, and this was a game changer. 1995, 96 was about when I was diagnosed. And it was the introduction of the first approved protease inhibitors. They were really the game changer in HIV, which people went from dying to living, you know, or started that process around it. It was still really rough. I remember, you know, I woke up one morning with a rash all over my body, and I thought to myself, well, what the hell is this? I had no insurance. I was young. I was living in the city of Chicago. I went into the Chicago Health Department. They did a series of tests. Back then, you had to wait several weeks for those test results to come back. And you know, like today, we have instant tests, right? You can get your results in a half an hour. I went back several weeks later. They said, you know, unfortunately, Mr. Gooding, you're HIV positive. And that was kind of it. They didn't hook me to any care resources. I think he gave me a prescription for AZT, and out the door I went, you know, and I didn't think, oh my God, I'm going to die. You know, the first thing I thought is, oh my God, I want to live. And so I started searching out what I needed to do in order to make that happen. And that was really in some of these trials. And at some point I was taking up to 20 or more pills a day. You know, I was living, but I never felt shitty until I started taking those pills, you know, so the quality of life had gone down. Now I'm fortunate enough to take one pill once a day that keeps my virus under control. You know, I'm healthy. I have my T cells are up in the normal range. I'm undetectable. Can't pass the virus on to others. So I'm feeling pretty good about that. In 2010 really was the first, under President Obama, we came up with the first national strategy for HIV/AIDS. One thing that's not in here, in 2012, the FDA approved Truvada for PrEP. That's a once-a-day pill someone can take who's at risk for HIV can take to greatly reduce the chances that they can become exposed to the virus. And that initiated another change, so the national strategy for HIV/AIDS was updated again in 2015. In 2020, the state of Illinois rolled out what they called their Getting to Zero plan, which means with the goal of getting to zero new infections, zero deaths by the year 2030. And testing and people knowing the status, getting in care, it's a big part of that plan. Another really, I think, historical win for us, especially in the state of Illinois, is in this year, 2021, we finally repealed the HIV criminalization law in Illinois. You know, HIV is the only disease that's criminalized and it was really done out of a knee-jerk reaction in the 80s and early 90s. That otherization, right? It's not us, it's those other people we've got to protect ourselves from. And now it's mainly used against persons of colors and correctional settings and for behavior that we know no longer transmit the virus. So it's great to have those repealed. And as we think about World AIDS Day, this is a worldwide issue as far as criminalization goes. And hopefully some other folks can get on the same bandwagon that Illinois has gotten on in making sure that criminalization isn't a barrier to people getting tested, knowing their status, engaging in care, and really allowing us to have open and real conversations about sex, sexuality, and what we like, what we don't like, and who we're having sex with. Next slide. So a little bit, am I going into these slides, Alec, or is this you again? It's me? Okay, so HIV 101. So what we do know about HIV, it's a retrovirus that, and retrovirus, it really means that it needs a human host to survive. So that infects and depletes the immune system, specifically your CD4 or T cells. Your T cells, if you think of your immune system like an army, your T cells are like the generals in that army, right? They go around, they find the infection, tell your immune system how and where to fight that infection. So they're really important. So the normal range is about 1,500 is normal. So we want to see people up in that range. Unmanaged HIV can eventually progress to AIDS, which is acquired immunodeficiency syndrome. But that doesn't have to happen now. And Roslyn and some other folks will talk about that later in this presentation. Is really, we have a really full toolbox in addressing HIV. And there's people shouldn't be progressing to HIV, from HIV to AIDS, although they still do. And I think, and that's due to various other factors, from institutional structural racism, lack of access to care, perceived need, all those other things kind of fixed into there. It's primarily transmitted through unprotected sex from mother to child, through injection drug use, and really that exchange of fluids. It's found in blood, semen, preseminal fluid, breast milk, vaginal fluids, and rectal mucus. So those fluids, or any fluid containing any one of those fluids, can be at risk for exposure to HIV. Next slide. And right now, currently, there are 37.9 million people worldwide living with HIV. That's a big number. And I think there's another caveat in here, is that now, especially in the United States, we have an aging population with HIV. I think they said within the next decade or so, more than half of those folks living with HIV will actually be over the age of 50, which I'm in that demographic right now. 1.1 million people in the United States are living with HIV. 45,000 people in Illinois, 28,000 people in Chicago. I think what's not highlighted in this slide, that doesn't show up in these numbers, is the fact that there's a significant amount of people that don't know their status, that aren't aware of their status. So they really don't show up in this number. And I've seen some numbers as high as 20 to 25% of folks living with HIV may not know their status. So again, that's why some of the work these folks are going to talk about today is really important. Next slide. Or was that my last slide? So I am gonna turn it over to my esteemed colleague, Rashonda.
Thanks, Brian, for all the good information and for sharing your personal story. So I just have a couple slides. I'm going to be talking about the intersection with race, politics, and HIV. So a few of these points I'll elaborate on, and then I have a visual in the next slide. But first things first, one of the things we see with HIV and AIDS is that it disproportionately impacts certain populations. So Brian did allude to some of this, but We know that there's specifically around, it's going to impact racial and ethnic minorities, gay, bisexual, and other men who have sex with men. Those are what we sort of see in the numbers with how and who HIV impacts. In 2019, the highest rate of HIV was among Black/African Americans. And then that was followed by Hispanic and Latino populations, and then persons of multiple races. So one of the things that Roslyn might touch on is that we see the same disparities across other illnesses like COVID. We consistently see the same disproportion with who it impacts. And so you'll kind of see why we're even bringing that into the conversation, because there's a lot of overlap, right? So a lot of the same stats that we see is going to impact those same population groups, unfortunately. Which leads me into my next point. In the city of Chicago, Chicago has one of the highest rates of new HIV diseases. And from years 2009 to 2013, we saw 39.4, this is a percentage of persons that were diagnosed. So all of these numbers and sources, we have it linked in the slide. So I have a little link down at the bottom. But again, Chicago is one of the highest areas. And also it's because Chicago is pretty large in the state of Illinois. So that's going to be another reason why it's high. But again, of those amounts, these are sort of the numbers that we are seeing. And again, same populations groups is who is going to impact. And then next, HIV exposes and exacerbates fault lines within social and economic inequalities and injustices, which are really political. So when we have a conversation about race and politics, like these things are married. There's definitely some intersectionality going on there. And even when Brian was talking earlier about the politics around it, one of the things he noticed was it didn't even really get national attention until it impacted somebody who somebody knew, right? It impacted a member of the president's family, even though the disease was already happening in the world. And there was something else I wanted to mention about sort of recognition around HIV, and that was with Ryan White. So one of the programs that we kind of house here at PHIMC, which we'll talk about a little bit later, is funded through the state through Ryan White Part B dollars. And for those of you who have not heard of who Ryan White was, he was a young 13-year-old Caucasian young man who got AIDS through a blood transfusion at the age of 13. And then when he went to school, he experienced discrimination with him being able to go to school. And as a result of him and his mother kind of advocating for fair rights and things like that, then that's when the CARE Act was approved. It actually was approved, I believe, 1 month before he passed away. But he was told at the time that he was only going to have 6 months to live, but ended up living for, I believe, 5 years after his diagnosis. So thinking about it didn't even really get national attention until sort of these conversations around politics started happening and who it impacts, right? So when we think about politics and HIV, there's a couple of reasons why it's kind of racy in the political world. But one is going to be there's sort of a prejudice and a stigma, which we'll talk about shortly, with HIV and how it's transmitted. So that's always going to be kind of touchy. We also are going to talk about it can be transmitted through injection drug use and things like that. So when we talk about that, all of that's going to really start some political talks, because it's also going to impact policies and the laws and things like that that are made for who's going to get the attention, who's going to get the resources, what neighborhoods, what communities are going to get the attention. So when we think about policies and laws and things like that, it's going to impact how we address HIV, not just as a city or state, but nationally as well. So next slide, please. So I wanted to bring this because I'm a visual learner. I like to see pictures. I like to be able to see things. So I wanted to put this slide in because this shows new HIV diagnosis with the most affected populations in the US. So this data is around from 2018. So it might be a little bit different current. But as you can see, again, it's basically a visual of what I just said. We know that it is going to impact largely African Americans, the African-American population, the first number is through male-to-male sexual contact. But then, as I mentioned earlier, it's going to kind of go from there. So then you have Hispanic and Latino for male-to-male sexual contact. And the numbers on here, you'll see it says Black versus other racial and ethnic groups. And again, nobody wants to make it a race war, but we do see it disproportionately impacting. Same thing we saw with COVID, though I don't have those numbers. So maybe Roslyn will touch on that a little bit later. So I just wanted to provide this visual. And again, like I said, it kind of goes from there. We see that it's impacting African-American women, heterosexual contact, Hispanic women, white women, etc. So you'll see the disparity visually as well. So that's my 2 slides, and I'll be here for questions at the end. Next slide.
Thanks, Rashonda. So before I kind of get started and start talking about stigma when it comes to HIV/AIDS, I think it's really important for us to sort of know, I think Brian touched on this when it came to history, is that there's just so much history in sort of trying to come up with this presentation and trying to touch on all of the different components of HIV. It's really hard. There's so much that goes on. So many things are interconnected, and it's really, really hard a lot of times to sort of separate those things out. And like Rashonda was saying, there are so many things that sort of just have a hold on HIV and different impacts, and they all interconnect, and it's really hard to discuss one component about it without talking about everything else that sort of goes along with it. So I wanted to sort of set the stage and sort of just define stigma. So according to the Merriam-Webster dictionary, stigma is a set of negative and often unfair beliefs that a society or group of people have about something. And so these beliefs are usually about certain behaviors, experiences, and identities, but they have huge, profound impacts on the way that they shape self-perception, social interaction, and institutional policies and practices. And it even extends to social systems, laws, and then even the way we access resources and who has access to different resources. The problem with it is that stigma often acts as a mark of shame that's viewed very, very negatively, and it contributes to a unique power dynamic in which stigma exists in personal, interpersonal, and structural levels, which results in increased obstacles to care. And this is how inequities arise. And so HIV has really often been associated with negative perceptions of people living with or thought to live with HIV. And so as such, the stigma is directed at people that live with or are thought to live with HIV, as well as people and groups that are associated with people living with HIV. So very often, like family and friends. And so some of this stigma can sort of transfer on to other people. And so there are a few different types or major types, I should say, of HIV stigma that we sort of see play out in the real world. And one of them is this inappropriate fear of contagion. So a lot of people sort of hold these attitudes that are really reflective of them fearing getting HIV from just casual contact with people. So things like sharing a coffee, giving hugs, like sometimes like I've seen and heard people talk about like walking past someone that's living with HIV and like, if I'm in the same room with them, will I get it? And so there's this really big fear, and a lot of it, a lot of times stems from ignorance. People sort of go with what they were told growing up and they don't really question it. And so they sort of take it as truth. And I'll sort of talk a little bit about how we can undo those things. And so another type of HIV stigma that we see a lot is negative judgments about people living with HIV. And a lot of times these attitudes reflect a lot of blame and shame, and people sort of cast moral judgments against people living with HIV. We also see enacted stigma and discrimination. And so this includes a lot of interpersonal forms of discrimination, like isolating people or teasing people living with HIV. And then we see a lot of institutional forms of discrimination, which I think Brian and Rashonda both sort of touched on. And these are ways that like stigmatizing and discriminating against people living with HIV are sort of built and interweaved into the systems, and how a lot of these systems are sort of built upon these principles. And so like things like being fired from work or denied healthcare because of HIV. And I think while in the US there are really major strides to sort of end those things, in a lot of other countries across the world, they are still very much present. And so then the last sort of stigma that we really see happening is this compounded stigma. So this is the idea that when we talk about the idea of intersectionality, we're talking about stigma that people face for more than one thing, right? So if somebody has HIV and is also a gay Black man, then we're talking about somebody that's receiving stigma for living with HIV, for being Black, for being gay. And so all of these things really compound and have a significant impact on the way people are treated, and then how they also often view themselves. And it takes a lot of work to sort of undo. And so we also see these compounded stigmas extend to sex workers, intravenous drug users, and then men who have sex with men. And so where does all of this stigma sort of come from? A lot of it is rooted in fear, and it's rooted in ignorance, right? Like people just aren't aware. I think when sort of as the US was learning more about HIV and AIDS, when it first sort of sprung up, a lot of people said that it was like the gay disease, right? Like it was punishment for these men choosing to be gay. And so there's a lot of that that's sort of still very persistent all across the world and across the US too. And so a lot of times this manifests through discrimination and social ostracism that's directed at people living with or thought to live with HIV, as well as individuals, groups, and communities that interact with people living with HIV. I think I've been in situations where like I stand up for someone and then it's sort of immediately thrown back at me like, why? Like, do you have it? And it's sort of this idea that like in order to stand up against something, like you have to be part of it, right? And that's not the case. I talk about it a little bit later on, but one of the ways that we can sort of combat stigma is not necessarily to be an ally, but to be an accomplice, right? So somebody that's going to take that extra step and also advocate for people when they are and when they're not in the room. And so very often stigma about HIV and AIDS is tied to sexuality, gender, race and ethnicity, class, whether people are intravenous drug users, whether they are sex workers. There are a lot of sort of components that goes into this, and it all sort of combines together and results in a cycle in which people that hold systematically marginalized identities are seen as deviant. And I kind of want to take a second to like think about what that word deviant means, right? And it's like, well, deviant compared to what? And very often they're deviant because they're not cis, they're not heterosexual. Very often they are people of color. And so it's like not fulfilling these sort of standards and ideals of the patriarchy, of white supremacy, and all of these things. And so it's like when you're not, when you don't have access to those things, you're seen as deviant, you're seen as wrong. And so what sort of happens with that is people that hold these marginalized identities because they don't belong to that group are sort of seen as the cause of the AIDS epidemic. And so in turn, what happens is that HIV and AIDS are associated with those systematically marginalized identities. And then people that are living with HIV are assumed to hold those marginalized identities. So it's sort of this like feedback loop that just like continuously feeds off of one another. And then there are just ways that we need to sort of insert ourselves to sort of break it. And so there are a lot of effects of stigma, and a really huge one is self-stigmatization. And so a lot of this is internalized. And the way I would sort of describe self-stigmatization is it's the shame that people living with HIV experience when they internalize the stigma that's sort of being thrown at them. And it results in things like negative self-image, social isolation, and then also increased risky behaviors. But outside of that, and also sort of combined with it, like I said a little bit ago, it's sort of hard to distinguish out all of this. We also see limited access to care. One, because people living with HIV are scared and fearful about what their clinicians are going to say, and what potential stigmas they're going to have to face in care settings. But also because, like, we've seen the case where clinicians and other staff at healthcare sites don't want to deal with people that are living with HIV, or they're ill-equipped. And so for them, it's very often easier to sort of turn these people away rather than to learn what they can do to support them, which is really unfortunate. And then the last sort of way, and this is also not an exhaustive list. Like, there is so much that goes on. But a lot of what we see is also socially ostracizing people living with HIV. And so ways to reduce stigma. The first thing I would say is reflect and speak up. I think the thing about stigma, and we can even expand it to like bias, is that we all have it. We were all, none of us were born in a vacuum, void of any sort of external factors influencing what we think. And so because of that, we see a lot of, like, it's hard when you grow up in sort of one sort of environment and think about things a particular way, because to you it's normal, right? That's what you know. But just because that's what you know, that doesn't mean that that's right or that's appropriate. And so a big way that we can combat stigma is sort of reflecting within ourselves to see what stigmas do we hold. And in addition to that, it's also speak up. I said this a little bit ago. It's this idea of not just being an ally, but being an accomplice. I really liked in Brian's sort of biography, this idea of him being an agitator. Like, the way that we sort of disrupt and dismantle these systems is by being agitators. Because if we sort of go with the flow, nothing's going to change. But if we're all sitting there like at the bottom, rocking and shaking things up, it's going to fall apart. Which sounds really scary, but the beauty about that is that we're then able to recreate it all in the best way possible. And so another thing we can do is recognizing institutional stigma. And so this is the ways in which sort of the institution builds these things in and makes them like a normal and ingrained part of it. And we see this a lot in policy and legislation, where it's a lot harder to sort of undo, because we're not necessarily talking about like changing people's minds by like conversations or things like that. There's a lot more sort of legal work that has to happen with that, but that doesn't mean at all that it is impossible. Another way to reduce stigma is to respond to the needs of people living with HIV, right? So like providing them with access to housing and access to care, because it's really hard to sort of get out of a really tough situation when you're being discriminated against for living with HIV, and so you don't have these opportunities afforded to you. But you know that like if you had housing, stable housing, if you had a stable income, if you had all of these things, then you sort of don't have to worry about them, right? There's also humanizing people living with HIV. So kind of like I said, like this idea of ignorance, when I think it's very easy when you sort of aren't face to face with somebody that lives with HIV to have all these ideas about what type of person they are. And I know from a lot of my work, I've noticed that when people sort of have that face-to-face interaction and are really able to connect with someone, it's like, oh, all of those things that I was taught growing up actually aren't true. And it really changes people's perceptions. And so in a similar way, including people living with HIV in service delivery is super powerful, because they also know sort of, they have inside knowledge about what's going on and ways that they can support others that are in similar situations. And then engaging the community at large is super important. I think that's why a lot of us are here tonight, to learn about this, so that we ourselves can become accomplices and agitators and disruptors, and all those great things. And so all of these approaches are not to be used by themselves. They're all to be used together. They all build upon one another. And that's sort of the way that we can truly enact a culture shift to reduce stigma. And so together, they account for the range of stigmatizing conditions that enable HIV stigma and individual structural stigma and discrimination to continue. And so stigma and stigmatization truly work best at the intersection of culture, power, and difference. And because of that, it's sort of key to upholding the current social structure. And so things like community organizing and like community building, along with working with people that are living with HIV and their accomplices, right? Like all of us can be accomplices. That's sort of like the vital and key component to dismantling such an oppressive structure and reducing stigma. And so, having said that, I want to pass it off to Roslyn to talk about sort of different scientific advancements and innovations that have been made to sort of start this work. It's not necessarily social, but it definitely has that sort of social impact, because like I said, like all these things are so closely tied together. So passing off to you, Roslyn.
Thanks. So I'm going to briefly talk about some of this very quickly, because Brian already talked about some of it in his biography. But I'm an immunologist by training, and for 5+ years I've been doing HIV research. And all of this is connected, as Aleksandar had just said, is that you can't have the science without the social, and we cannot change the science without the social. So currently, for folks who are living with HIV, there's antiretrovirals. As Brian said, the first antiretrovirals were approved by the FDA in 1987. That was AZT. It was not a fun pill, to say the very, very, very least. Combination antiretrovirals, so taking multiple medications to combat HIV, was approved in 1997. And so right now, there are 6 different types of antiretrovirals that are available to people. And most people take a combination of 2 or sometimes 3 of them. And now you can take 1 pill a day. You can take 1 pill a day rather than 20+ pills a day to prolong your life. I do want to point out, because like I said, you cannot have the science without the social, that the average cost, this is without insurance, the average cost per year is $36,000 to $48,000 for antiretrovirals for one individual. That was in 2018. That was the most recent data that I could find. I also want to point out that according to the US Census from 2020, the median earnings, so what you take home, not what your income says, but what you take home, the median is $41,000. So let that sink in for a second, because if you look at this, someone can spend their entire earnings on just to survive, and that's not okay. One major advancement that we have made recently is U equals U, and this campaign has changed so many ways of thinking in the medical field, so many ways of thinking in our social lives, and has really, really made such a positive impact. And what this means is undetectable equals untransmittable. And so people who are living with HIV cannot sexually pass HIV on to any partners if HIV cannot be found in their blood, which is absolutely amazing. And my hope is that this campaign will really, really help knock down the stigma. And so this was confirmed by 3 different clinical trials looking at both heterosexual couples and then male-to-male couples. Alex, you can switch it over. One major thing that has happened in science advancement is trying to prevent HIV, right? So now there are different things that a person can take to prevent them from acquiring HIV, and that is called pre-exposure prophylaxis, or PrEP. So basically, it's treatment for prophylaxis. So you treat before if you're at risk so that you don't acquire HIV. And so right now on the market, there's medication. There's Truvada, which Brian brought up, that was approved by the FDA in 2012. Truvada now has a generic, so it's more affordable. Fun fact, if you live in the state of Illinois, you can get PrEP for free. Yay, we have a link at the end of the presentation for you if you're interested. Truvada is for everyone who's at risk through sex. It has a 99% efficacy, and injection drug use, where it has a 74% efficacy. There's a new drug, newer, that's out, Descovy. That one is for sexual risk only, and it's for people who are not assigned female at birth, who are at risk through vaginal transmission. So that one is a little bit more limiting. There's also a vaginal ring that WHO just came out and said that they're promoting. I actually know the scientists who work on the ring, and it's a monthly vaginal ring. If you know what NuvaRing is, the birth control NuvaRing, it's very, very similar. So it's basically a ring that you insert into the vaginal canal. It releases those antiretrovirals locally. It has a 35% efficacy. People are very, very excited about it. There's also other methods that are being tested. There's an implant that has antiretrovirals in it. The lab that I came from was working on the implant. And there's also an injection that you can do that's in clinical trials right now that is for every 8 weeks. You go, you get an injection of antiretrovirals, and that will also work as PrEP for you. And then there's vaccines. There have been several failed vaccine trials using different vaccination technologies to date. The most efficacious and exciting vaccine trial that we've had to date is the RV144, which was done in Thailand, on sex workers in Thailand. And this, like I said, it's most efficacious to date. However, it only has a 31% efficacy, which isn't enough for it to continue on. Moderna, yes, that Moderna, the COVID Moderna, they are working on an mRNA vaccine right now for HIV that is in a phase 1 clinical trial that has a lot of people talking. So hopefully more to come. And you can switch to my slide. So one of the things that we were asked to bring up is, what lessons did we learn from the HIV epidemic in response to COVID? What did we learn from HIV that we could take with us to COVID? And so, as I said at the beginning of, before I started talking, I'm an immunologist by training. I was doing HIV research. When COVID hit, infectious disease researchers were well equipped to work on the new highly infectious SARS-CoV-2. So SARS-CoV-2 is the virus, that's the name of the virus that causes COVID, which is the disease. And so we were ready to go, fully equipped with all of our biosafety level containment centers and resources to help us. So having experience with working with highly infectious diseases was a good base for a lot of people. What we also learned from the HIV epidemic is that human behavior plays a vital role in fighting disease. Again, this goes back to the social. You can have all these tricks up your sleeve that work scientifically, but if it doesn't actually work for people's everyday lives, it's not going to work. We need to actually listen to people and know what they want, what's going to help them with their lives, make their lives easier and better, in order for us to find treatments, to find a cure, to find anything that's going to help with COVID as well as HIV. Another thing is equitable healthcare is absolutely necessary. Rashonda talked on this. When it comes to race and HIV, when it comes to COVID, or I pulled it up actually, Rashonda, as you were talking about it, because I wanted to make sure I got the numbers since I don't have a visual. For our for Black or African American non-Hispanic people, hospitalization is 2.6 times higher than the white population. For our Hispanic and Latino population, hospitalization is 2.5 times higher. Death is also higher at 1.9 and 2.1 times higher for both populations respectively. COVID is hitting the same groups as HIV did and still does to this day. And so we need equitable healthcare in order for us to combat either one. Another thing we learned is that vaccines cannot work alone. Treatments are also needed. As I said, our vaccines for HIV failed, so we are relying on our treatment. With COVID, we know that vaccination has been a touchy subject, and so treatments are also needed. Next slide, please. And so one question that I get all the time, and I've talked to probably 100 people now at this point, different people about getting vaccinated for COVID, is how do we have a vaccine for COVID, but we don't have one for HIV? And there's a lot of reasons. As you can see, I have a lot of reasons on this slide. I have lots of feelings on this, but I know that we're running out of time. So I'm going to try to be brief. The first is different sites of viral transmission. HIV, if you remember from the very beginning, you can get infected from various ways, right? So you have sexual, which depending upon which organ you get infected in is going to have a different immune response. Mother to child, so that's the gastrointestinal tract, going to be a totally different immune response. Injection drug use, different. Whereas COVID is a respiratory virus, so you are taking it in through your respiratory, through your mouth or through your nose. So it's different in sites of how the virus is transmitted. Also, where does the virus live in our bodies, right? So again, this comes back to how our different organs are going to be infected. And it goes back to the differences in PrEP. So if you remember a couple slides ago, I said that, you know, certain medications for PrEP are approved for everybody, certain medications are not. And that's because biology is different and the immune responses for different biological places is different. And so this is also going to affect how we can create an HIV vaccine that is going to be able to cover everybody. HIV has different subtypes. So COVID, we know, have all these strains. It's all in the news. We hear about it all the time. HIV has 4 different strains. The main strain is strain M. Strain M has 9 subtypes. So 9 genetically different subtypes of one strain. And those subtypes are creating a huge, huge barrier in how to create a vaccine that's going to cover everything. So subtype B, for example, subtype B is most prevalent in the Americas, Western Europe, and Australia and Asia. But subtype C, which is most prevalent in Southern Africa, the Horn of Africa, and India, actually represents nearly 50% of all people living with HIV. And so if you need a different vaccine for each subtype, that's something else that we need to think about. Another thing is global pandemic. COVID hit everybody. It spread across the world very, very rapidly. Everyone can get infected versus an epidemic, which HIV is, and who is getting infected. So as Brian mentioned in the beginning, it took Reagan from 1980, Brian, correct me if I have my years wrong, 1981 all the way to 1985 to even mention AIDS. And why did that happen? Who was getting infected? People of color, injection drug users, sex workers. I think this also plays a very large role in our response, how fast we are to respond to things. Who gets funding for research for this? Like Rashonda said, when we start talking about it, it gets into policies and it gets into changing the systems and breaking the systems down and recreating them. And that is heavy. And I think for a lot of people, it could be a very difficult conversation that they don't want to have. For resources available, again, same thing. When COVID hit, as a scientist, I know this firsthand because it's actually affected my job. All funding for science stopped unless you were doing COVID research. So a lot of infectious disease researchers, like HIV researchers, stopped what they were doing and started working on COVID. It was how we were able to get to where we are today is we had so many people rapidly switch over. All of the money, all of the time, all of the effort was dumped into this because it was a global pandemic. My last point is HIV is weird. There are so many nuances to HIV that we cannot explain. I have been doing HIV work in the bench, in the trenches for over 5 years, and there are still things to this day that surprise me. Every day with HIV, this virus surprises me. My old boss had been working on HIV since the beginning that it emerged, and he still says to this day, it surprises him every single day. I think that's my last one. Yep.
I know we are fairly short on time, so if I can ask for like 10 minutes, is that okay? Just to do 2 more really important slides. So to Roslyn's
That's
point,
fine.
thanks, thank you. To Roslyn's point about like really great ways that that organizations are working on HIV, I wanted to touch on 4 innovations that PHIMC is actually doing. So I will, all of us, the 4 of us, all work on different aspects of each one of these. And so I will pass it off to Rashonda to give a really brief description about community reentry.
Okay, so really brief. The Community Reentry Project really focuses on correctional facilities. We know that folks who are incarcerated, they definitely are at risk or have a higher risk because they're in a more confined setting. Also, we know that there is no condom usage or anything like that in correctional facilities. So this project is funded through the Illinois Department of Public Health and seeks to assist individuals who have HIV or are at risk for contracting HIV from a correctional facility, get the resources that they need to stay connected to care once they are released. So the reentry piece is really on the community side, coming from a correctional facility, because we, as we say in public health world, good community, good prison health or correctional setting health is also good community health. So that's the Community Reentry Project.
And then Brian, did you want to touch on RIG?
Sure. RIG, the Regional Implementation Group. It's actually IDPH funds the Regional Implementation Group to provide high impact HIV prevention services across the state of Illinois. Since 2012, PHIMC has served as the lead agent for Region 8, which is suburban Cook County, funded through the Department of Public Health. And through that, PHIMC awards and monitors about $1.9 million to 15 different organizations across suburban Cook County, provide a variety of HIV prevention services and risk reduction linkage to care services across the Cook County. And this is in direct in alignment and guided by the National Strategy on HIV/AIDS and in support of the Illinois Getting to Zero plan.
Thank you. And then Roslyn and I both work on routine HIV screening and protecting our patients, or POP. So routine HIV screening really focuses on expanding routine screening throughout Illinois and implementing strategies for that to do it sustainably. And POP works really, really well with that. There's sort of 2 components of the same program, and it is an initiative that aims to reduce stigmas and biases that hinder HIV screening and care by focusing on affirming care, and that is also funded through IDPH. So the last sort of thing that we have here are some resources. So there's a link here to the PrEP assistance program that I believe Roslyn mentioned earlier. There's also a link to Getting to Zero Illinois and the National HIV/AIDS strategy that we talked about earlier. So I'll leave this up here. And then I also have our contact information on the next slide. And then if anybody has questions.
Could you also put these links in the chat so people can copy them? Thank you. And if anybody has, I know we're like out of time, but I'm fine. I'll stick around if everybody else wants to. So if anyone has any questions, feel free to speak on your mic, or you can type it into the chat and I will read it. Right now I'm going to stop the recording